I'm Tina Nelson. I'm with the American Board of Medical Specialties, and I'm the manager of the Portfolio Program. Again, thank you for joining us today. And we have several people who are going to be sharing with you today. Before we get there, though, I do want to call out my colleague, Spencer Walter, who is behind the scenes running the Zoom call, and some other folks from the ABMS who have joined us today as well. Mr. Tom Duncan, Mr. Rich Waters, and Ms. Sylvia Magriel. And anybody else from the ABMS, if I have missed you, thank you for joining us today. We appreciate having you guys on the call as well. It looks like we are filling up. So we're getting just about everybody here, which is wonderful. Spencer, could you please go ahead and go to the next slide for us today? Thank you. So I just want to share with you some different things that we're going to be talking about today, spending the next hour together, if you will. And we're going to start with kind of a program overview and some information just about the history of the portfolio program. And then we're going to share and hear from 4 different portfolio program sponsors, whom I'll introduce in just a few minutes, and talk a little bit about what you guys might need to do or how we might be able to help you establish a portfolio program in your own organizations. So again, my name is Tina Nelson. I have been with the ABMS for 7.5 years. However, I've been with the portfolio program actually since 2013. So that is one thing I want to share with you, is just kind of my own perspective, so you know where I come to the table from. I started a portfolio program at the University of Wisconsin with a physician colleague of mine there in 2013. And in 2015, when the portfolio program was transitioning over to the ABMS, they were looking for staff to lead the program, and I applied for that job very excitedly and was really happy to be able to come to the ABMS and manage the program, better stated, help all of the portfolio program sponsors, many of whom are friends and colleagues that I've known for years and years and years. So I'm very excited to be in this role, and it's important for me to know that you know that I also have been a portfolio program sponsor myself. Some things we want to make sure we do today are really just sharing some pearls and some lessons maybe, or really some aha moments, things we wish we would have known years ago before we joined the portfolio program. What if we could think of anything that somebody could have told us that would have been so helpful? What are those things? And many of you who are joining the call today know a little bit about the program. Maybe you've heard from me, maybe you've heard from other staff at the ABMS or spoken with other folks about the program. Maybe this is all brand new to you and you thought, yeah, this is something I just want to hear a little bit more about. Either way is great. We're happy to have you. So we are going to share some pearls and ideas with you today, specifically things we wish we would have known at the beginning of our relationship with this program. So I just want to take a minute and let you guys know kind of like I said, the history of the program. So in 2009, the American Boards of Internal Medicine, Family Medicine, and Pediatrics were in conversation with the Mayo Clinic about the fact that the Mayo Clinic was doing a lot of quality improvement work, clearly, and they were really interested in how can we get this work approved for maintenance of certification Part 4 without having to continue submitting different applications to all of these different boards and paying all of these different fees and you know, adhering to all of these different timelines, some of which went really well with our commercial funding grant requests and stuff, and some didn't at all go together. So how can we address this better? We want to be able to serve our physicians, and we want to be able to work with the member boards. So this idea was born that instead of submitting an application for one quality improvement activity or project and to 3 or 4 different boards, so that I could have one project approved by internal medicine, family medicine, psych and neurology, and maybe peds all at the same time, I could just submit one application, an organizational application even. So vetting how I implement quality improvement, determine what's going to be addressed in terms of quality work in my organization. What are the metrics? What types of metrics is our organization looking at, and what can we implement into some of these projects? A better way to approve a slew of QI activities and offer credit to the physicians who are participating in that work instead of these one-offs. And the idea for the portfolio program was really born. And to be honest with you, when my boss came to me at the time and said, Mayo Clinic is working with the tri-boards on this program, they're calling it a pilot right now. What do you think of that? I was like, sign me up, because it saves me time, it's going to save us money, and it just makes so much sense. We're able to help our people get credit for this work that they're doing, and we're doing it anyway. Pardon me. I also want to make sure that you guys know, so that's kind of the background where the portfolio program came from, what it was born out of, and some key things I want to make sure that you know before we step to the sponsors and really have them start sharing some key information with you. There's some things I need to make sure that you guys walk away from this call knowing. And the most important one for me is that the portfolio program is truly intended to be localized to your organization's needs. Yes, we have requirements in place, but they're loose and you're able to modify them to meet your needs. That's really important. So for example, some organizations have a committee, a quality committee that was even born or created for their portfolio program. And that's what they use to review different project applications to make sure that people are, meaningfully participating, and they run things through a committee. Others have no committee, and there's not a requirement that you have a committee. It's up to you to decide how you would do that. Other things, you'll maybe even hear about today, that some organizations require all of their physicians or all of their quality improvement leaders to go through formalized quality improvement training. Others have no such training. Again, that's up to you. Other things like the services that you're able to provide within a given program. Some portfolio program sponsors sit down with physicians side by side and work through a program or a project application rather, and help them understand and help them identify, okay, how can we think about an aim statement, and how can I help you identify metrics maybe that you can utilize for this, or interventions that maybe you'll put into place. And others don't have that service. Others only approve projects that are coming down from the top level, organization-wide QI activities, for example, that don't necessarily need this type of, let me sit down with you and work through an application. Again, that's up to you guys. So very simple projects, very complex projects, anything can be submitted here. You can use technology and a very robust LMS, or you can use Excel and Word. Either way is fine. And then again, with regards to the projects, and one of the questions we get asked a lot is with regards to the timing of a project. How long does a project have to be? And there is no minimum requirement. The requirement is that the timing makes sense for the project. So you can submit easy or very complex projects, some that maybe span 2 months and some that maybe span 2 years. And we see all of those things coming through the portfolio program. Additionally, it's important to note that not only can the participants in these activities receive credit through the portfolio program, but also your QI and your project leaders and coaches and trainers, they can also get credit through the portfolio program. And then just within this last year, due to COVID, we've really been kind of stepping into a different space with creating specialized templates for the portfolio program sponsors, specifically one for COVID. We have DEI forms, we have opioid forms, and a few other things. So the point is, the projects that you can submit are very wide ranging. They can be short, they can be long. They can have 15 people, they can have 1,500 people. And that is all going to be up to you. Next slide, please, Spencer. Great. So I'm going to take just a moment and introduce our presenters today to you. And we're going to start with Nationwide. And from the Nationwide Children's Hospital, we have Dr. Mary Ann Abrams and also Ms. Laura Lehman. So a little note about Nationwide, they've been a sponsor since 2011. They have submitted just about 2,000 completions. So about 2,000 people have received credit, or let me rephrase that, about 2,000 times have people been awarded credit through Nationwide. Some of them, maybe the same person received it twice for different projects and those kinds of things. So they've got lots of people participating. They've got almost 300 projects that have come through the program so far. And their structure is that their program is sitting in their QI department and is funded by their QI department. Dr. Marianne Abrams is the multi-specialty portfolio sponsor, portfolio manager. She's a physician and has an MPH. And Laura Lehman has an MBA, and her title is the MOC QIE project manager, and that's nationwide. Next, we'll also hear from the University of California, San Francisco, Dr. Jeff Tabas and Joey Burnell. UCSF joined the portfolio program right around the same time that I did when I was at Wisconsin in 2013. So we've known each other and kind of been buds for a while. It's great to be able to work with these gentlemen. They have over or just about 3,500 completions. So 3,500 times they have submitted people for credit to the portfolio program and almost 200 projects. Now their program sits in the CME department, and they're funded by the School of Medicine and their CME department. And again, Dr. Jeff Tabas is a professor of emergency medicine, and Joey Burnell has a master's degree, and he is their program manager. The next organization that we'll hear from is Michigan Medicine, Ms. Tasha Vocali and Ms. Ellen Patrick. They have been a sponsor since 2011. They were the third organization to join this program, I believe. They have almost 4,000 completions, 150 projects. Their program sits, like nationwide, in the QI department, and they're funded through their QI department. And Tasha is an attorney. Ellen has a master's degree, and they both co-lead this program together. And then finally, we'll also hear from the University of Utah, who joined the portfolio program in 2014. And we have Dr. Rick Wiggins, as well as Sahar Pestel. Oh, I'm going to slaughter it, Sahar. Miss Sahar, because I don't want to slaughter her last name. I'll ask you to pronounce it when you are on screen, Sahar. And they have completed, or rather have submitted over 1,000 completions and have over 150 projects as well. Their program sits within their CME department and is also funded by the School of Medicine and their hospital. So Dr. Rick Wiggins is the Associate Dean for Continuing Medical Education, and Sahar is the MOC Coordinator at the University of Utah. So all of these folks have been in the program for almost, over a decade and almost a decade. And though they're all academic medical centers, I do want to point out, because I know some of you that have joined us today aren't from an academic medical center, there are other types of organizations in the portfolio program as well, including associations, societies, hospitals, other types of health systems, foundations, government agencies, and more. So having said all of that, next slide, please, Spencer. Oh, actually, I lied. We can pop them down. So we are going to go ahead and get started with Nationwide Children's Hospital. So for all of you who don't have your cameras on, feel free to turn them on if you want. We're going to sit kind of in this gallery mode for most of the call because we don't want to look at slides. We want to look at each other and we want to be able to see your faces. So we'll go ahead and get started with Nationwide, like I said. So as we've been prepping for this call, we've kind of been talking about, gosh, you know, you guys, what would we really tell people who are thinking about the program now, 10 years later than we all started? What would we share with them? And kind of, you know, what are our pearls for these folks? And Marianne and Laura started in a great place for us. The very first thing that Marianne, Dr. Abrams said to us is, Tina, senior leadership support is critical for this program. So Marianne and Laura, can you guys just say a little bit about that, about why you say that and how someone might go about getting senior leadership support for implementation of this program?
Yeah, I'll go ahead and start and ask Laura to chime in and fill in. Neither Laura nor I were here when Children's made the decision to become a portfolio sponsor 10 years ago. But we do know, partly because where we are embedded now, is that it did originate from the really robust quality work that was already underway at Children's. And a lot of that credit goes to Dr. Richard Brilley, who was our chief medical officer, who was very invested in patient safety and quality. So it became a really natural fit to complement and build on and almost to give back something to all the people that were moving forward in children's as quality, emerging and existing quality leaders, so that they were able to, as you really nicely described, Gina, to provide that path for them to earn their MOC Part 4 credit for recertification and maintaining certification, but it also just aligned beautifully. We have a really great quality improvement services department with a lot of people with specialization in QI processes that help support our physicians, our nurses, our pharmacists, our social workers, a whole host of folks who go through the Quality Improvement Essentials course that Laura helps lead. And then those folks establish projects. And Tina, you just did a great job sort of describing what we provide through our program. We have small individual projects, we've got hospital-wide projects, we have projects that are expanded, they're really important, and then they expand into other departments, inpatient, outpatient, et cetera, that have grown and sustained or refined their goals. A good example of that is adverse medication events. First, we looked at the worst ones, and now we're diving deeper. Same with pressure ulcers. Pardon that pun. But anyway, I hope that kind of gives a thumbnail sketch of how that leadership support was fundamental for launching and sustaining our involvement. And then it was embedded sort of in education because of the QIE course that Laura helps run, as well as quality improvement.
Gotcha. Thank you so much. And Laura, would you mind just telling a little bit about that QI Essentials course for those organizations that do have something internal and they think they're going to maybe funnel physicians or QI leaders through that?
Sure. So echoing what Dr. Abrams mentioned, that we do have kind of a top-down QI atmosphere at NCH, and we're so lucky to have that. And our Quality Improvement Essentials course was actually started by our CMO. So he was kind of the driving force behind it, and we're about 10 years into it now, training over 450 internal and probably about 150 external, that we invite external organizations to participate in it as well. It is a 6-month intensive training course that we run anywhere from all of our senior leadership through down to our floor nurses. We do have an application process. They usually come to us with an idea of a project they want to work on throughout those 6 months. And then at the end, then they present to senior leadership as well, which is a great opportunity for everybody that goes through the course. And so that's actually a requirement for all of our project leaders. So all of our MOC Part 4 projects are actually required to be led by somebody that has completed our QIE course, or at least co-lead the project with somebody in training.
Got it. Okay, great. Thank you. Now, something else that you guys shared specifically when we were kind of getting ready to talk with these folks was the fact that you felt it was really important to strategically place and leverage this program so that you, in your words, Marianne, could elevate CME, education, QI, and MOC. So can you guys just talk about that a little bit? I mean, like you said, you started out in CME, now it's in QI. I imagine there's a reason for that. And what has that done for the rest of your CME and QI and any participation in MOC QI activities?
I want to, just to clarify, CME and the QI Essentials course, and therefore the portfolio program, we're all in the education department. The portfolio program was not specifically under CME, which is interesting. I've learned about that from our colleagues who are going to be speaking later on this call today. But regardless of where it sits, we have to revert to Dr. Briley and his leadership, which is now Dr. Morris has taken over and continues to build and grow on that. And the previous Vice President of Education did a really fabulous job talking and presenting to all the departments and divisions so that they recognized we're here and we can help you. We're here to help you. We're not here to add. We're here to help. And as you say, Laura and I and the folks who were in our shoes before us would walk people through, because some people are very new to this and very tentative, and others, they're really ready to take it and run with it. So we're also I think in terms of leverage, what we're seeing now is the opportunity to illustrate and advocate for how does QI intersect with really important things going on in medicine in the world, equity in particular. So we're really trying to drive people who are launching a project to say, how does this address health equity? How could it? How should it? How can it? How might it? Are you looking at your data that way? And we're using that as a leverage point and a way just to prompt people to think about it more deeply than, oh, it's a QI project and I need to do this and I need my MSc. And we're also trying to do the same thing with our trainees. They're required to have a QI experience as part of their graduation requirements. And we really try to align the MOC program with their expectations and to encourage them, if they co-lead a new project, to apply for MOC Part 4 approval so they can earn and/or bank, if they're a resident, their Part 4 credit, because those 5-year cycles come around really quickly. Laura, do you want to add to that?
Sure. I kind of had a unique experience because actually when I started at Children's, I started in the CME department. So strictly just doing CME, I also managed the MOC Part 2. So having that, starting point of understanding MOC was a great foundation. So even if you are managing Part 4, I encourage everybody to kind of take a look at MOC as a whole. It's unfortunately so different between all the boards and whatnot, but you can get a base understanding that will really help you kind of piece all the parts together. So when I transitioned over, still in the education department, to managing Part 4, I still kind of had that knowledge of Part 2, and the connection with that department, though, was still really important because the course we were running was also approved for Part 2. So we needed that connection. It was great that we already had that established, but then I also then had to develop a relationship with all our QIS service member reports that are helping out throughout our course to gather all the data and everything needed for the Part 2, Part 4 projects. So that was really important as well. So almost like a relationship between the two departments, no matter where you fall, is really important.
That point is really well taken, Laura, and thank you for saying it. I will share with you guys just a little bit about the University of Wisconsin's program that we started. We did couple QI and CME. That was not my idea. It was my old boss, and he was brilliant. I just was the follower. So I was working specifically with a physician in QI. I was PI CME manager, like that was all I did. So it was the perfect coupling. And you guys brought up several different care team members, not just within the QI course that you mentioned, but also just these other offerings. And one of the things that is kind of unique, I think, about the portfolio program is that it really does encourage this entire care team. It allows an environment for the entire care team to be working together. And my question to you is, how do you think the portfolio program has impacted that type of care team cohesiveness or care team work through quality improvement activities at Nationwide?
Laura, I'm happy to chime in, but I don't want to always go first. Do you want to start?
Sure. Just quickly, that I think it's so important that although, the MOC Part 4 is very physician driven, and we're actually trying to start involving our PAs more, through the course that we run to promote the Part 4 projects, we really encourage all the teams to be multidisciplinary. If it's a nurse-led project, there's bound to be probably a physician and lots of other different specialties on there. But letting them know that they can submit a project for Part 4 credit will just probably entice the physicians and PAs to participate more in that project.
And I would echo that, as well as Laura mentioned at the end of the QIE class or series, the cohort, we have one in the spring, one in the fall. At the conclusion of those, there's always the report. It's a formal report, and invariably, well, we always require them to include their team members and what their roles are. And some of those are indeed led by non-physicians. But even if, whether it's a physician or not, invariably there's some recognition of, we couldn't have done this project without our pharmacist. We couldn't have done this project without the social worker. We couldn't have done this project without the nurse lead on the floor. And I would also add that we do encourage our teams to include parents, patients, families as part of their team to the extent possible, because that input is input that you can't get from anyone except patients and families. They know what they need and what their experience is and what they don't know, and how important it is to explain things clearly or to provide certain services or processes to make it easier. So we also foster that as well.
That's great. Thank you, ladies, so much. So we'll switch just for a moment to the University of California, San Francisco, or I'm sorry, did I say that right? San Francisco, UCSF. Sorry, guys, I lost my acronym. Jeff and Joey, how about that? Dr. Jeff Tabas and Mr. Joey Burnell are from the University of California, San Francisco. And like I said, they've been a sponsor since 2013. We joined right around the same time when I was at Wisconsin with these two gentlemen. So I've been working with them in multiple different ways for quite some time, and they've got a lot to share with you guys today. Jeff, I'm going to start with you, because one of the key points that you brought up that I think is really pivotal for the people on the phone to hear, you said something about the fact that physicians really want to be certified, Tina, and we need to be able to help them in that space. Can you talk a little bit more about that for the folks on the phone?
Sure. I think just a little overview that this program is a real win for both the organization and the individual faculty. And that is sort of the message point that needs to be promoted. Both the faculty and the organization win. And just a little shout out, not all credentialing organizations are smooth and well run. This program is so well run and so responsive with the leadership team of Tina and Spencer that it's a pleasure. It really is a pleasure, because we work with many accrediting organizations. So real shout out, and it should help allay some anxieties of applying for, to be a sponsor. What we found is we did not quite understand, and we find that people still do not understand the purpose of the program. What we synthesized is this is not necessarily a program to turn your non-QI faculty into QI faculty. So you don't want people who've never done QI to like submit a project to do QI. And it's not even really to reward your QI leaders with their maintenance of certification. What we found this is fantastic for is to engage your unengaged faculty. So it's a carrot for the QI leaders to get all of the faculty on board. And as an example, we were working with the OB department, and their residents were doing a QI project of getting Foley's out after minor gyne surgery within 24 hours. And what the QI leader from gyne said is that senior faculty said, I'm not going to take the Foley out in 24 hours. This needs to stay in, because that faculty wasn't even aware of the QI project. And that was not a QI faculty. And I had led the QI in our department in emergency medicine and realized that we did it in a very isolated fashion. The QI leadership team worked together with everyone, but we just didn't want to burden our faculty with what we were doing. And as a result, there was much less buy-in. So what we found this does is this gets buy-in for the faculty to support the QI project. And it's a real win for the QI leaders, because they can offer this as a carrot to their faculty. Listen to this project, see what we're doing. don't badmouth it behind the scenes, support it. So that's the real win that we've seen, and people love to have their maintenance of certification supported. It's huge, you know, it's like one thing off their shoulders. So once you teach the QI leaders to present it that way to their faculty, like, we're not trying to turn you into QI leaders, we're trying to get you to support our project, I think it's a real win. And yeah, so that's my take on that.
That's interesting. That's a distinction I haven't heard anyone else say out loud before. So thank you for saying that.
Cool.
What about getting a program off the ground? You guys shared a little bit about kind of the lift that this was. Is it, from your perspective, was it moving mountains, or was it displacing molehills?
Joey, did we draft the original application together, or was that before you came on? I can't remember.
That was actually before I came on. And I think that was a collaboration with some of the original members of the portfolio program.
Yeah, it was. So I would say that, echoing what Dr. Abrams and Laura said, leadership support is, AKA funding, is the issue. So leadership support really means, will they fund it? And you know, some programs were funded by the dean's office, like ours. Some were funded by the quality department. Some were funded by the clinical practice group. And what we did is we got the initial proposals to their organizations from about 5 or 6 different places. The University of Colorado was really, really helpful. But I think we got yours, Tina, as well. I think we got program proposals, not the applications to the program, but the proposals to the organization about how they were going to sell it. And you know, you can make your program as big or as little as possible based on how much they're going to fund it. And one of the strategies that we had to decide was who we were going to answer to. So we didn't even ask the CMO. We just put the CMO at the top of the org chart for our MOC program and said, we're sending you an annual report. And so, yeah, so they became the, you know, the reporting sponsor of the organization. And we didn't end up getting funding from them, but it sort of supported legitimacy. Yeah, so our dean, Bobby Barron, is the one who supported it initially and then got funding through the dean's office. But that is by far the hardest thing to get set up with this program. And what I would suggest, what we did initially as sort of proof of concept, is we just did this on the weekends, myself and our accreditation manager in CME, and we just dipped our toe in with like 1 or 2 applications to the ABIM or ABPs or ABFM, just as a proof of concept. And then we said, look, we can get this for everybody. We can get this for 18 different boards. So unless you have someone who's like clearly gonna fund this, you know, that's a way to at least see if it's going to work.
And that is an incredible approach that, had I still been at Wisconsin, I wish I could have taken, because I will be honest with everybody here and say, as a shock to nobody who knows me well, I definitely made it more difficult than it needed to be. And I still see folks who are doing that, because it's one thing that I didn't understand coming into this program, and I still hear from people who are new to the program, is, okay, wait, so there's 18 boards. So what are the requirements for all of them? No. The 18 boards that have agreed to be part of the portfolio program have agreed to a set of standards that are, I'm going to say, different. They're not outside of what the regular board requirements would be for an individual, but they're a subset of those requirements, and they're the same for all 18. So if you submit one project, the requirements are the same for all 18 boards for that project. You don't have to specialize. And that's something I didn't understand. Speaking of something I didn't understand, Joey, when we were preparing for today's call, one of the things that you mentioned was, I think that maybe people don't realize how easy it is to get a project approved. And you and I have spent, no exaggeration, hours and hours and hours and hours on the phone, pre-portfolio program and post, just talking through projects and different things that you guys are doing or want to do. So could you talk a little bit about that with the folks on the phone?
Yeah, I mean, I have to echo what Jeff said. The portfolio program is just making things easier, even easier than it was when we first joined in 2013. They have resources to show you how easy it is to approve a quality improvement project for your maybe entire campus or just for a division. And right when we saw how easy it was, we created an application that helps document a project, and that's all it does. It ensures that it's using some QI methodology. And then there's a really, really easy attestation process where the physicians just say, yeah, I did participate in this project, and then here are some things that I learned. So that's what I wanted to say, that this program just makes it a lot easier for folks to earn MOC credit. And Spencer has done a great job at putting up the resources on, is it a wiki? I think it's a wiki. No, it's not a wiki, it's a Teams page.
Teams now.
Yeah. And so, and they also, what also is helpful is the organizations that are part of the portfolio program sponsors are always available to help any new or somebody that's thinking about becoming a sponsor. They're always willing to sit down and talk with you about what their process is and showing you how easy it is to approve a project and give credit.
Thank you so much, Joey. And thank you too, Jeff. So we will now transition. We're going to switch to Tasha and Ellen from Michigan Medicine. And I will say in advance, Ellen has a little bit of a scratchy throat. She wanted me to apologize to those of you on the call. So Tasha will be doing most of the talking, but Ellen definitely does 50% of the work. So no mistake there. So Tasha, as we were preparing for this call, you guys had some very specific points. And one of the things that you said is that it's really important for people to know and to understand who and where this program benefits. Can you talk about that a little bit, how it has benefited in Michigan Medicine, like what populations and just what you are seeing from that?
Yeah, sure. Even and yes, I want to say first of all, Ellen does definitely do at least half of the work, and I'm sorry that she has a scratchy throat. I know that she really wanted to do some public speaking today. So yeah, to answer your question, even though our program has been well established, we've been a sponsor for over 10 years. In the beginning of the pandemic, when we were asked to reevaluate all of the programs across our institution during as part of an economic recovery plan, and we needed to convince the leadership of the value of our program again. So one of our former partners, Dr. Van Harrison, was able to calculate that our program saves almost $1 million a year in physician time. And to get that number is not too wild. To get to that number, we thought about what would happen if our program didn't exist, and it would go back to the olden days of where physicians carry out QI projects through guided modules or document their own projects and self-report to their boards. And we came up with some calculations and on assumptions on physician salary at an academic medical center, and multiplied that number by the number of attestations we submitted on behalf of physicians in 2019. And it did add up to about $900,000 of physician time that's saved through that, which is pretty incredible. And in 2020 and 21, the savings were even greater because we were able to offer credit for the important improvements that physicians and PAs made during the pandemic. So we, the ABMS actually streamlined the process for COVID-related projects, which was really incredible. And our physicians really took advantage of that really took advantage of the opportunity. And I think something like last year we had something like 900 attestations go through between all of our projects, which was pretty incredible and definitely record setting for us. I think in the past we did have like an average of about 200 to 300 per year.
It's interesting that you say that, Tasha, because Spencer is still kind of tabulating our numbers from last year, but I can tell you we beat our previous records by thousands, thousands of submissions. And that's not even counting all of the COVID. With COVID, there's thousands and thousands and thousands more. So people really, really appreciated that and were able to utilize that, most importantly, to get credit for their physicians, PAs, and some specific specialists who were participating in those, in that work, which, as we all know, was essentially everyone. Those things will be available for at least another year for the portfolio program sponsors, so they can continue to submit. The boards are all very well aware that physicians are still working in the COVID space, so that's not leaving us anytime soon.
Oh yeah, we actually, it was so nice to be able to be a bright spot in the darkness of the pandemic, because when we email people, they're thinking, oh gosh, what do I have to do? And they're like, oh wait, this is something good. we don't get something good very often. And to kind of finish answering the question, you asked about the benefits that the program provides, and we look at it from different levels within our institution. So at the institutional level, we're thinking about how it saves money, and the physician level, we're thinking about how it saves time. And then even in the department level, in the quality department, we are able to align the MOC Part 4 portfolio program with our institutional and quality department priorities, which is kind of a cool thing that we're doing. We try to focus on offering the incentive to projects related to the top priorities in our institution and in our department. So we work with our continuous improvement and clinical design colleagues to offer credit to participants in existing QI projects. So we do have lots of different areas where we get our projects from, but one of them is the way that we align it with our priorities.
So Tasha, does that mean that you guys also allow individual physicians or care teams to submit applications? If they, like, I discover something in my practice that I would like to improve upon, how can I get credit that way through Michigan Medicine?
They could. It has to be sponsored by their department, though. We require at least a department chair to be aware of the project, so nobody is, running off and doing random quality improvement work that's not supported by anybody. So it is something that it has to be supported by their clinical department.
Gotcha. Thank you for that. Let's see. Oh, last thing. I knew there was something else I wanted to ask you guys about. And that is, so when Nationwide started talking, they were talking about how they required the QI course for anybody who's going to be in a leadership type position. But what they didn't touch on was employment. So, or rather certification requirements, not employment. But some organizations I know that employ physicians also require then those physicians to be certified. And I think you guys are in that space you mentioned. So how do you feel how do you feel the portfolio program has supported just that fact? Like, does it show physicians in the organization, we're here to help you? Not only do we require that you have this, but we're doing this for you. Like, how do you tell that story?
Yeah, so I mean, we do require, we're an integrated delivery system, and we require all of our physicians to be board certified in order to be credentialed to deliver services. And they, back in 2011, when we started the program, the president of our medical group was very cognizant of that fact. Okay, we're requiring board certification for our physicians. So what can we do to help them make it easier instead of letting them kind of be on their own? And that's actually where the support for our program came from, as both Dr. Abrams and Dr. Tabas mentioned, that leadership support is critical. And because the program can fit into so many different places within the institution, support can come from many places. So when we wanted to get this program up and running, we had a chief medical officer who was a surgeon, and thought, hey, that's a great idea. I'm not going to give you any money for it because it doesn't impact me or my colleagues, because we're surgeons and we don't really need to benefit from the program. So the president of the medical group was an internal medicine physician who was aware of what physicians were doing to maintain their board certification at that time. And what that was that they were participating in these quality improvement projects and self-reporting to their boards. So we actually had someone who would sit down with an individual physician side by side at the computer and say, what are your board certification require? What does your board require in order to self-report on this QI project? And they would write down all of the things that a physician would need to say to their board in order to get credit for the project. They would make a photocopy of what they wrote down and hand it out to all of the other physicians who participated in the project. And the other physicians would have to type it into their board portal and get credit for it. So knowing that that's what people were doing, this program just simplifies that process so much. It takes all of the board requirements and turns it into one requirement. So you don't really have to think about, oh, do I need to do 2 cycles for this board, and do I need to have this kind of data for this board? All of the requirements are streamlined, you can have one easy application, and it really does make that a lot easier.
Thank you so much, Dasha. I really appreciate it, you guys. All right, so now we will transition to the University of Utah with Dr. Rick Wiggins and Ms. Sahar. So I am going to ask Rick to share with you guys his a statement that he made to all of us while we were preparing for this call. And it was related to the fact that you noticed Dr. Higgins as well as Sahar's background, right? So they've got the University of Utah Health back there, the red one, and then they've got the portfolio program sponsor one, and then there's another one that's the ACCME. So you all, or most of you, I'm sure, recognize that. Rick made a comment about ACCME and about what it was like for him coming to this position, learning ACCME requirements, and implementing a portfolio program, or taking over a portfolio program, I should say. Can you share a little bit about your thoughts about that, please, sir?
Yeah, it was a great learning experience. As a radiologist who is a teacher and an educator, I've kind of been in the CME game running conferences for 25 years or so, but I've always kind of been on that perspective. So moving over to my position as Associate Dean of CME and working with the School of Medicine, I had to relearn all this stuff, which turns out is a lot more complicated than I thought. What is the relationship between CME and MOC? And part two, CME is kind of the same as CME, but not quite the same. And then when I started learning about everybody else, everybody has different rules. It was bad enough for us in radiologists. The rules seemed to constantly be in flux. But the surgeons and the internal medicine, the pediatric and OBGYN, they all had different rules. And then it just gets more confusing when you talk about nurses and pharmacists and PAs and social workers and dentists and what are their rules for continuing education. Trying to get everybody under one umbrella is an extremely complicated thing, as we always talk about moving a battleship. So it was a lot of learning and education. And that's a lot of what we do, just explaining to everybody, you have CME credits for state licensure, and we have MOC for your board certification. And Sahar spends a lot of time doing a great job educating everybody about who has a lifetime certificate and who doesn't. You guys need to do all of this. We are a department to help you do that. It is very interesting to hear the different groups that, even though it's very different background, you kind of all end up kind of at the same place. We're very different. That we had a Dean Vivian Lee come in, who was a radiologist in 2011, who spent a lot of time talking about value and quality. So we spent a lot of time talking about the $4 trillion the US spends on healthcare. It's 20% of the GDP. But what can we really define when you think about quality and service divided by cost? That's really value. And she made a big effort, which was great for us in the long run, to kind of make a chief value officer or chief quality officer in every department that we had, which is great for us now because we have a pool of people that are already kind of prepped and set up to review those applications. So it is very interesting to us. And we had a quality department, like you heard from some of the other groups. And after some discussion, the quality department moved over to the CME world, which is very helpful in terms of defining and educating people about PICME and CME and MOC and QI projects and the portfolio program. What are everybody's rules? What do they have to do? Most people are very happy that they hear that there's somebody there to help them just navigate this process and define it and figure all out. And Sahar has done a great job about educating everybody, often meeting with own departments and telling them what their rules are and helping them navigate it.
Sahar, do you want to add to that?
No, I think Rick did
Okay.
a very thorough explanation of what we do, what I try to do, and how we try to communicate that MOC is something that's here, and it's something that's probably not going to go away, and that it's something that we are here purposely to help with. So,
and knowing that you guys run both a CME shop and a portfolio program shop, do you feel like it's hard for you to continuously meet the requirements of the portfolio program?
no. Everyone else has already been saying this earlier, but I just wanted to echo it. You guys make it so incredibly easy. I already see 2 questions in the chat that I'm happy to answer really quickly as well. But basically, I started off in CME, and that's what we were doing. And our program came to us from the value office that Rick was just talking about. It came back to our CME office. And so we're all together, and I'm the maintenance of certification coordinator. So I'm helping out with part 2 and part 4. So I have a very good familiarity with both, which is good because most of the time when I talk to our providers, it's been changing in the past couple of years, but initially when I would talk to people, they weren't really sure of what MOC was. They weren't sure if they needed it, even though they do. Our institution does require board certification. So anyone who doesn't have a lifetime certification has to participate for MOC. And our whole thing is to get people credit for work that they're doing. We don't design education in general. We are a decentralized, smaller office, and basically we work with people that are doing things to get them credit for that work that they're doing. And so since we're already taking care of CME, folding in MOC part 4 was actually pretty easy. We have, yes, please do contact all, oh, I'm speaking for everyone else, but I'm already going to say, I like to talk about this. This is what I like to do, is outreach. And so that includes my peers, not just the providers who need help. So if anyone has any questions, please email us. But basically, we did PI CME projects with our Part 4 program. So it all went together really well. And actually our PI CME projects, which we don't do just PI CME on its own. We started off doing our Part 4 projects, and then we just started folding in PI CME because it was so easy. They both meet the same requirements. You just have to make sure that you've documented the PI CME earlier than you do need to for Part 4. And we've actually used that in, I have no idea who else here is also ACCME, but we used that as part of our self-study when we were applying for commendation, because these projects nicely meet outcome requirements for commendation. They basically are really good for improving healthcare quality and improving patient community health. Like, we were able to fulfill those criteria very easily by taking our data from our Part 4 projects that also got PI CME. So I see people in just the QI office doing it, and it makes sense. I say it also makes sense if you're in a CME office, which is what we have. So it really works for a lot of people, and they make it really, really easy. I went from being like, do we need to have your logo on every piece of paper that goes out to people? Do we need a special statement that has italics in it, like the AMA PRA Category 1 credits that you like? All of the CME statements that I had to keep an eye on to make sure we were in compliance was not a concern that we had with ABMS. And ACCME is also very friendly whenever we've talked to them about questions, and ABMS is also, like, anytime we have any questions about something and we're not sure we're in compliance, they are quick to respond to us, and then they're also just like, nope, it's pretty easy, you're good. And we're like, oh, thank goodness. So if you're already doing CME and you already have that infrastructure and you already have that work there, it's not too hard to add in and maintain Part 4. I think some other teams that we've talked to have mentioned that if you're getting started with the program, like there's some programs, Part 4 programs, that are run by 0.5 FTE people. So it really varies on what time you have and like what your manpower is, but it's very doable.
Thank you. Thank you for that. And I do want to address the fact that we are 2 minutes of the hour. I had no doubt in my mind coming into this call that this would happen because the conversation would be so rich. I will say before going forward, yes, you guys will get a follow-up email with everybody's contact information, as well as lots of documents that they all have very graciously been willing to share with you all. So you'll get lots of information after the webinar, including a link to the webinar and some marketing information, some communication information is probably a better way to say it. But somebody was asking, do you have this information so that we can share with others? The answer is absolutely yes. One question I do want to address by Jennifer, is there an easy way to find out how many of our physicians need MOC and from which boards? My best suggestion for you would be to go to your credentialing office and ask them, because there's not an easy way for us to be able to give it to you. The best thing I could tell you is that you'd have to ask the physicians or go to the boards, and that's not what you want to do. So if you have a credentialing office, that's where I would go for that. So we will answer all of the questions that have been posted either via email or via phone call with you guys. But I do want to ask, just the last minute of the hour, that Spencer, if you could please bring the slides back up for us, because I just want to make sure that we kind of hit the nail on the head when we say these are the things we wanted to make sure that you guys walked away from this call with. And I just want to make sure that we are able to give you those key points. So perfect. What you're looking at on the screen are the basic points that we wanted you guys all to have from this. Yes, there is some investment required upfront to implement a program. It's not moving a mountain. I made it moving a mountain personally, and it didn't have to be. So it's much more like moving some molehills, and it can be a mountain if you want to do that, but it doesn't have to be. There's loads of different ways you can implement and tailor this program. It's natural fit with CME and QI work, absolutely natural. All I did was PI CME, and this just fit right on top of it, like easy breezy lemon squeezy. Once set, the requirements are easy to manage. We're available to the sponsors all the time. We respond to them before we get to other work because we want to make sure that we're meeting the needs of the people that we serve. That's what we are here for. And we do our best to try to continuously improve our own program as well, so that we're continuously serving the people that need us the best. And Jeff is saying, thanks, good luck to everybody, and feel free to reach out. So thank you for that. Okay, next slide, please, Spencer. Very last one, I just want to make sure that everybody has our contact information. My email is there. Some of you have already received my emails. Like I said, you will get follow-up information shortly. We're going to send you a bunch of information, and I'm happy to schedule a call with anybody who would like to do that. As well, you'll get contact information for all of the presenters, as I mentioned, who are happy to talk with any of you. So thank you again to everyone for joining us today. Thank you again to all of the presenters for agreeing to do this call with us. We really appreciate you. Have a wonderful rest of the day and a wonderful rest of the week, everyone. Bye-bye.